apologies for that, which you do mainly. And thank you so much for being here. I'm really excited to hear about your work. I've had the pleasure of knowing this tremendous scholar. I was doing the math. I'm like, oh, really? I'm like 7, 8, 6, 7 years. And watching your work grow, just both as just a human, but as a scholar, and then seeing you as a new faculty member in the school has just given me tremendous joy. And I'm really excited for you to share your work with everyone today. So I'll move out. That was longer than 1 minute, but thank you for the time and excited to hear from you, Erin. Thanks. And you'll talk for about, what, 20 minutes and then we'll shift?
It'll probably be more 35.
30, okay, and then we'll shift to
yeah, and then we'll shift to discussion. Whew. I'll just echo Dawn. Thanks so much for being here. I know it's been an emotional 24 hours for many of us, and I just really appreciate your presence here. So I'm going to start out by, I'll be talking about some of my research, but first I just want to talk about sort of a systems approach in general and kind of orient folks to that. So a question, why do public health problems persist despite efforts to address them? So this could be problem, specific health outcomes that we don't want to see, disparities in health outcomes, low vaccination rates, any sort of public health problem that we can think of. I'm going to dig into an example here. So low colorectal cancer screening rates for low-income rural residents. This is something that's known. It's been known for a while. There's interventions to help address this that can sort of move the needle. But why does this problem really persist? So let's go through some factors here. So there's different modes of colorectal cancer screening. There's colonoscopies, FIT testing, which is an at-home method, Cologuard. So you can think of like, what are the different pros and cons? There's quality improvement efforts at the clinic level. Those can either be, good or bad. There's clinic level factors. There's sort of how good is the clinic at QI. There's provider buy-in, clinic leadership buy-in, staff training, provider knowledge. There's sort of these bigger factors too, right? So there's Medicaid policies, access to primary care, clinical guidelines, quality metrics, insurance access. And then there's all these patient level factors too, right? So hesitation, values, stigma, cultural norms, transportation, income, time availability. And so there's also these connections between the factors too, right? So provider buy-in can affect how the patient outreach works, clinic level factors, the policies can affect how clinics operate. And so it's not just one thing, right? It's a lot of different things. And it's the combination and the interaction between those factors that kind of make this problem persist. And so there's what do we do with this, right? So anytime you kind of know a problem intimately, it ends up looking like this if you try to map it out, right? Because you know the problem, you know these interactions, but what do we do with this? So you could decide to look at one factor, right? You could one relationship. You could decide to look at how health literacy affects hesitation or sort of patient attitudes towards screening. You could control for other factors, saying all other factors being equal. What does this look like? You could design an experiment around that or a study. You could also look at like quality metrics, how that influences clinic leadership buy-in. So this is, this is sort of standard scientific method, right? Like zooming into a specific factor, let's really learn and understand that. And, there's nothing wrong with this approach. It's foundation for modern medicine and science. It has a lot of value, but it's also, doesn't necessarily give you a comprehensive perspective sometimes if that's what you need. There's also data-driven approaches where, this sort of big data approaches where you're looking at a bunch of different data around a system, looking at how generate a certain model or certain patterns from that data that inform your understanding of a system. And this can also be useful depending on your question, but it kind of puts your model in a black box but it can be good for like, what's the signal out of some of this noise? Implementation science research, this is super bare bones, but you're looking at an intervention or policy, a change. You're looking at strategies that influence that intervention. You're looking at the relationship between intervention and outcomes. And there's lots of theories, models, frameworks in implementation science. but a lot of them kind of have this epistemological weight around what the intervention is and how that can be adapted to certain settings. Context is there's frameworks for identifying context, but a lot of times it's kind of seen as what are the barriers and facilitators that get in the way between intervention and outcomes. And there's, also a kind of call within implementation literature for approaches that kind of try to take a more holistic perspective or kind of realize that reality kind of looks more like this, right? And so, there's a call for looking at sort of what are the mechanisms here? What's the rationale? How do we understand this system to work? And, there's a need, I think, for approaches that let you have one foot in what's the research, what do we know from prior literature and examples, but also what do we know about the local context? And how can we really have this rich understanding of what this complex situation is? And so when we take a system science approach, we're sort of saying, we're starting with the assumption that reality looks like this. And we're we're sort of starting from an assumption that system behavior, so like the outcomes that we see is due to system structure. It's these interactions between factors. So I'm going to go through a few more premises here. So like I said, system structure produces system behavior. System structure here can mean, systems, institutions, it can mean power systems, it can mean how money, people, all these different things flow through systems. Another premise is understanding the structure can lead to insights about real points of leverage. So systems can also be really kind of counterintuitive. And it's sort of a starting point that if you really try to understand how these different these mechanisms work, we might be able to kind of better get at what might lead this to lasting change. Another premise is that interventions or policies are disruptions to the status quo. So Penelope Hall had an article around interventions. I think she framed it as events and systems, which is the same idea where, instead of kind of focusing on what's the intervention as the center, it's good to understand that like when you're trying to change something, the world, the context already exists. It has a memory, it has momentum. There's things going on in the world. And that when you're trying to change that, you're trying to disrupt that. It could be a positive disruption, but it's disrupting something that already sort of has weight in the world. And also how we think about systems and interventions matter. So it matters for how we interpret what's going on. It matters for how we act in the world. So system science is a big, broad tent, and I'll talk a little bit about a few methods here before I get into some more specific examples. So one method that I've been trained the most in is called system dynamics, and it's looking at feedback structures between system components and how that can affect outcomes. And the idea here is you kind of develop a map or model that's sort of a dynamic hypothesis of how we understand the system to work. And we say, okay, if we can sort of capture those dynamics, it can help us, we can use it as a tool for thinking about how a system works. Agent-based simulation. So this is a computer simulation method that involves a sort of two-dimensional plane, an environment, and then agents or beings, turtles that kind of move around there. And in agent-based simulation, you're assigning simple rules to the environment and simple rules to the agents. And so you can see where the sort of interactions between individuals and their environment lead to kind of emergent patterns of behavior. So with this, a kind of classic example is if you have a bunch of people or beings where they have a slight in-group preference, they slightly prefer to be around members of their own group, and you kind of let them wild, you end up with a situation that is much more segregated than any individual prefers, but that's just the sort of emergent pattern that happens out of those interactions. Network modeling, also, social network analysis is a part of that. It's looking at how relationships between individuals or organizations can affect the outcomes that we see. So there's more methods here, like microsimulation, sometimes artificial intelligence is put under this umbrella, big data, complexity science, lots of different methods. And I'm going to go just real quick through a few examples from some research I wasn't a part of, but just to kind of highlight the differences between these approaches. And I'm going to use the common example of tobacco use or smoking. So this was a study from Mills et al. That is looking at how interaction, it's causal loop diagramming, it's a method within system dynamics. And it's looking at how interactions between individual, environmental, and what they call sort of fundamental factors affect smoking behavior in, I think, racial, ethnic, minority, and low-income populations. And so they did this mapping based on some prior research and then with a group, and they used it sort of as a discussion point to be able to discuss how different policies might affect outcomes. This is from an agent-based simulation called Tobacco Town, where they were looking at how different policies for restricting tobacco retailers might affect outcomes. So they were looking at comparing policies where they sort of randomly restrict retailers, restrictions that are proximity based, like they can't be near a certain other retailer, or proximity to schools. And what they found was that the policies that succeeded kind of depended on what the what the neighborhood looked like. So dense urban and suburban neighborhoods, the proximity policies worked, and vice versa for the other neighborhoods. This is a study from Christakis et al. That looked at smoking through social networks. And you can see the yellow is sort of the smoking. And so you can see overall that smoking's decreased. But what they found was that smoking is very dependent on social relationships. It ended up being that there were sort of pockets of smokers around the network. Smokers got socially ostracized through these networks. And that it was very sort of highly dependent on social connections. And these different methods, you can see how it really depends what sort of question do you want to address, and then the method can be a good, there's different methods to address different sorts of questions. So I'm going to get into some of the research I've been involved in. So this was a study called Caravan. It has a weird acronym. I don't remember the exact one, but it was supported by the VA Office of Rural Health, and we were looking at challenges that veterans face accessing primary care. And so this is sort of a flow chart of how our process. So we interviewed veterans, VA and non-VA clinicians, veteran service officers, did interviews. We analyzed those interviews through a certain sort of coding method where we identified causal claims, assembled those, uploaded it to a visualization software, refined that model with a group, our advisory board, and then a group of interview participants, and then applied a certain analytical framework that helped us identify leverage points in that system. And then after this study and this follow-up study, this was used to identify an intervention that they were piloting. So not going to go into details here, but we have a interactive walkthrough of this model through this website, and it's cool because it can kind of like show you the different factors. But it's, you're sort of looking at all these different factors that affect veteran access to primary care. So I'm going to zoom into a piece and kind of show you how this works. So again, this is causal loop diagramming, and the basic idea here, let me see, is that you have a certain staffing need that's based on the contrast between your goal and how well you retain your staff. So when you need more, when your goal is higher, you ideally recruit people and it meets your needs. So this is what you call a basic goal-directed balancing feedback loop, where there's a sort of desired outcome, there's actions to sort of put that back into balance. And this is also showing how the rurality, in rural areas, it's harder to retain staff. And that can lead to problems with turnover and ultimately veteran satisfaction. So this, what we call a reinforcing loop, this R loop, is basically saying that when there's staffing problems, it puts more pressure on individual providers, leading to burnout, which makes more people leave. So there's this vicious cycle of when you have staffing problems, you have burnout, causes staffing problems. And you can see how this sort of, if all else being equal, you know, if there were plenty of people to hire, this balancing loop would do its job, but this reinforcing loop is kind of throwing things out of balance. And there's also additional pressure because in rural areas, the folks tended to take on more patients. There was a piece of policy called the Mission Act that, you know, this has been a known issue for a while, is veteran staffing and veteran access to primary care. There's a piece of legislation that allowed veterans to access care outside of the VA called community care. And so the sort of function of this with the dynamics is that, you know, if there's a sort of chronic unmet need, they sent veterans to community care, and that reduced the pressure, the hiring pressure on the system. When we talked to veterans and VSOs, they were concerned that over time, this sort of reduction in pressure, it's going to cause downsizing of VA facilities, and then, you know, sort of ultimately not the situation they want. And so you can, this structure is what we call, is where there's like this chronically undermet need, there's this workaround that then causes unintended consequences. This particular thing is called a drifting goals archetype, where you can imagine that this happens in some other situations too, where there's chronic unmet need, a workaround that then puts things where you don't want it. So this is an idea in system science called system isomorphism, which is just a fancy way of saying that similar structures lead to similar outcomes, and we can learn from one situation. If it has a certain archetype, you can sort of get insight at when that archetype pops up in another area. And before I go on with this, I just want to say that what I like about causal loop diagramming is that it's really communicating quite a bit of information in a pretty compact way. And you can also you can base your connections here on available data. You can base it on, the input from experts or from other community members. You can put in your own assumptions as long as you're sort of clear about what this is. The main idea is to try to get the story of how the system is working on the paper. And we've used this in a few different studies. One was we talked to representatives from Medicaid health plans, the CCOs in Oregon, and we sort of mapped out how the structures of how CCOs are incentivized to support clinics. And part of that analysis ended up finding that the way it's structured could end up inadvertently exacerbating the rural disparities there. We've also used this with the Northwest Evidence-Based Practice Center. I've been working with them on a few studies to sort of identify structures in some of their systematic reviews and using this as a way to communicate findings. So in this study, we took that big diagram and we applied this leverage point framework from Danella Meadows. And if you haven't read Thinking in Systems by Danella Meadows, it's a really good, really accessible book. I highly recommend it. But she talks about how there's sort of a hierarchy in types of leverage to change systems. So at the bottom, it kind of goes from least transformative to most transformative. So at the bottom, you can like tinker with the amount of a tax or subsidy. And that can work if your scope of your problem is small, but if the scope of your problem is big, that can be like rearranging the deck chairs on the Titanic. In the middle, there's the sort of structural changes around like redesigning system structures, redesigning information flows, how a system self-organizes. And then the highest points of leverage are paradigms, and sort of in transcending paradigms, sort of what are the thoughts, the beliefs, the assumptions that undergird all of the system structures that we have. Obviously, that's not easy to do, and I think it might be something that a lot of us are thinking more about lately. But the idea is that there's different types of leverage that can be appropriate for different problems. And so we applied this to our model, identified different policies and potential points of leverage that was used to form a discussion with our group that identified an intervention. A different study was called Smarter CRC, and this is going back to the colorectal cancer screening example. And this was, we used a causal loop stock and flow diagram, a slightly different diagramming method within system dynamics, to better understand how two screening interventions can affect screening outcomes. So this is the at-home screening with patient navigation for follow-up colonoscopy. And we base this on qualitative and study data, and we're trying to get at what's the study team sort of understanding. So this is the first diagram in this, and you can see how the basic, the flowy things at the bottom, and this is causal loop structures, and the boxes and flows are, it's what's called stock and flow diagram, where it's showing how patients, what are the different sort of places people accumulate in the screening system. So you have patients that are in need of screening, they get routed to different modes. Some folks are screen negative, kind of time back into screening eventually. Some folks get referred to follow-up colonoscopy, and then some folks get referred ultimately to oncology. And these factors at the bottom are sort of showing what are the patient clinic, what are the different factors that kind of get in the way of people moving through the system. So, if you have a flow where it's clinics identifying patients for visit-based fit screening, the provider knowledge and acceptance of that method can affect how many people flow through there. There's also sort of patient level barriers to getting follow-up colonoscopy. And so at first this was just usual care, right? This is what happens before an intervention. And this we've mapped on the smarter CRC interventions, where we're talking about mailed fit, patient navigation, and it's really being specific about how do we think that intervention is working? What are the mechanisms for this intervention? How are these interventions helping people move through that system better? And so it's sort of it's an opportunity to think, okay, if we're doing this, how do we think that's actually working? So in this study, this is an example of using it as kind of a theory of change that's really specific to the mechanisms of this intervention and the dynamics in the usual care setting. And this was sort of used as a proof of concept, but in a future, we have a couple grant proposals out now to kind of really embed this more in implementation planning. So the last example I'm going to talk about here is a system dynamics simulation model we're doing, where this is a partnership between the OHSU Office of Advanced Analytics, ORPRIN, and then some partners at UNC. And we have funding from the Oregon Legislature and HealthShare to look at the behavioral health system, especially the components around acute mental health crisis. And so they want to better understand, okay, if we want to improve treatment outcomes for people with severe mental illness and acute mental health crisis, where do we put capacity? Because if you're not familiar, system is very broken. Oregon rates really low in behavioral health outcomes, and the system is sort of chronically undercapacitated. It's strained, there's bottlenecks everywhere. And so they want to know, okay, if we're investing money, if we're putting more beds in a certain place, how is that going to affect people in other parts of the system as well? So this is a very, very basic schematic of our existing model. And so you basically have people in the community, some go into mental health crisis, and then there's the different places people can go. So mobile crisis, crisis stabilization, some people end up in the justice system, emergency services, acute inpatient, residential facilities, and all these red stop signs are sort of places where there's bottlenecks, and there's blockage and flow because of various different reasons. And to make this model, we're talking to a bunch of experts throughout the state, and we're basing this also on actual data, so looking at what is the average length of stay in certain facilities, that kind of thing. And so this might not look at it, and this is, like I said, very bare bones. Each one of these boxes probably has 30 actual variables in the system. And you can't tell from looking at this, but this has the same feedback structure as the causal loop diagrams. It's just sort of hidden, but you put numbers, you put math, you put ordinary differential equations behind this, and you can get a model that generates an estimated graph of behavior over time. So you're saying, okay, if we think the system works like this, at the end, we'll be able to have a dashboard where people can say, okay, what if we add a 16-bed facility at this level? What might happen at this other level? What kind of combination of factors might be necessary to help address this problem. The benefit here is that, you know, you can't just experiment by building a lot of extra capacity at a certain level. You know, it would be very impractical. So it's a sort of relatively lower risk way, very lower risk way to kind of experiment with different policies or different investments that might help improve outcomes. And we're still working on this. We're also doing a model on the youth behavioral health system as well. And yeah, the basic idea here is let's try to get this model to work as close to reality, to actual behavior as we can, and then to be able to use it as this like sort of what if machine to experiment with different interventions. So kind of zooming back out, when is a systems approach helpful? So when standard approaches seem insufficient to fully address your question or need. You know, if there's a standard approach that works, great, you know, but if it's really not, you're having trouble really trying to get at it, it could mean that you need one of these approaches could be helpful. When you want to understand how a system behaves, so this could be part of a needs assessment, sort of understanding how, what are the mechanisms underlying a certain problem, identifying leverage points, or identifying how interventions might work. When you want to synthesize different forms of knowledge, so like I said, you can base these models on a lot of different things, and you can also use it to develop shared understanding. So there's a whole literature on group model building, participatory modeling, where you engage a group that cares about a problem, you do modeling with them, and it really helps provide this clarifying lens to how do people think about this situation differently? How can we develop a shared understanding that then they can use to form a basis for future collaboration? And then to communicate complexity. Like I said, we're doing some of this with systematic reviews, or, you know, when there's kind of complex dynamics you want to communicate, it can be a method for doing that. When is this not appropriate? Well, when a standards approach is sufficient. Don't overcomplicate it. When you want to make a precise prediction. So, you know, even though these computer models can generate estimated graphs of behavior over time, you're really kind of using them to say, okay, when are things kind of getting better? When are things maybe getting worse? You're not going to be able to say, okay, at this date, X amount of people will have this mental health outcome. No, there's so many assumptions in that model that it's not that precise. It's not weather prediction, but it helps you understand in general what the behavior might look like, especially compared to different interventions. If you don't have the time or expertise, so a lot of times these are, you know, the causal loop diagramming, that's something that's pretty accessible, you know, that people can learn, but some of the simulation models, there's a lot that kind of goes into it, and it's good to have folks trained in those methods. When your problem or question isn't clearly defined, so what you don't want to do is try to model a system, because then you get a kitchen sink, you try to put everything in, it's not useful for anybody. What you want is to model a clear problem that you're trying to understand. This is, if you're interested, there's I got some funding from the Consortium for Cancer Implementation Science, from NCI, it's funded by National Cancer Institute, developed a sort of simple online module that explains some systems concepts, mapping and modeling methods, system science across phases of implementation, and then system science across the cancer continuum. And we're working on getting this published as well. It's the website's live, but the paper isn't published yet. Also, I'll be teaching a course called Systems Thinking for Public Health in winter term. We're working on getting a 600 level section of that as well. Right now it's as CPH 507, which is a seminar. It's sort of a temporary designation, so it can be hard for folks to find. But next year we're hoping to have a permanent course number for it. But in that course, I teach causal loop diagramming. It's meant to be a very introductory course that anyone could take. And they have an opportunity to learn this method and learn how to apply it to a problem of interest that they have, and kind of learn how to think about that differently. And like I said, no prerequisites. It's meant to be accessible to anybody. And I think it can be used as an elective in various programs. Some of my future work, I hope to do some more around using systems modeling to support implementation, like I mentioned. I'm really kind of jazzed about the idea of leveraging AI to identify causal structures in text data to help kind of smooth some of this. I think especially, some of like causal loop diagramming, I think some of these diagramming methods have a potential to be able to really synthesize a lot of different evidence and communicate what a body of literature is saying or body of data in a really cool way. And then I want to go more in the direction of climate change and health as well. Some citations, and thank you so much. Appreciate your time. I see a question here from Allison. Could you say more about how the results of Caravan were used by your partners once you identified the leverage points? Yeah, so this was, we had a group, our advisory board, and it's sort of an expanded version of our advisory board that kind of was part of developing that diagram and then part of applying the framework. And we kind of used it as a starting point to kind of discuss the pros and cons of different sorts of policies. Because, if you look at the system structure, you can say, okay, this type of leverage point would have this sort of leverage, this type of point, this would have this type of leverage, but it's kind of independent of political, there's different factors that you need to identify. So it was really kind of used as a starting point for some of those discussions. And it was good to be able to kind of circle back and say, okay, what could be some of the potential impacts from these different ones? And so it can be used to like identify potential unintended consequences. Was that the only question in the chat? Yeah.
I'm wondering if you can share more about the methods by which you get to a causal loop diagram. Like,
Yeah.
Is that brainstorming? Is that surveys? Is there models of fit tests or?
Yeah. All the above. It really depends on what you need. So when you're doing a group, when one of the key outcomes you're looking for is developing a shared understanding with a group, you really want to kind of take that group from the beginning and have them involved at the beginning. So there's different exercises you can do to kind of get them to articulate different systems concepts, but essentially it boils down to like a group, a whiteboard, like kind of developing this shared model together. When we do, some of our studies that we've done have been more systematic, where we've collected our qualitative data, we've coded for causal structures, where we look at, okay, here's a potential causal link, here's a potential feedback loop. We kind of look at what are some of the kind of contextual clues that make you think, okay, this is a certain sort of feedback loop. That was part of my dissertation research, was kind of further developing a method to be more systematic about that. So kind of putting in a spreadsheet, they're having a certain method for revising that to be kind of as true as possible to the source data. Sometimes that's not as important. Like if you're looking to have a model that kind of captures a group's mental model, you want that to be more participatory. If you're really looking to kind of base it on systematic review data, for example, in some of those studies, we did sort of a qualitative synthesis, had the qualitative findings, and then from that level of synthesis, describe some of the dynamics. So it really, there's different ways to do it. It really kind of depends on how, what's going to be important to your audience. Is really kind of close rigor to source data going to be important, or is it involving different people in the process? I think what you don't want to do, which is, is just sort of do it yourself and then sort of say, this is how it is. I think that you have, as with any sort of method, you want to be transparent about how you came up with a model, how much is your own assumptions or ideas versus the ideas, or where do you get your different source data. What I like about Kumu, which is the visualization software I use, is that it's interactive. You can click on any causal link, any feedback loop. There's sort of this information panel that pops up. So we attached like direct quotes that supported certain causal claims and feedback loops with that Caravan model. In other models, we've used it to put citations behind different parts of the model.
How do you decide, like, this is it, we're good? We've been through the model, we don't need to iterate anymore?
Yeah, well, you know, good question. I think it's when your funding runs, I don't know, yeah. There's, it really depends, again, on what the purpose of it is. If you're basing it on certain source data, you kind of apply a process and see what works. But yeah, this is the idea too of, you know, going back to like a living model, or like how in projects where you're trying to use it to capture your own understanding, like within a study team or within a group, it would be not, you know, it's great to kind of, and this is like the same thing with any kind of theory of change, is like, it's great to articulate at the beginning. It's best to really kind of use it in an ongoing way and try to compare how are we, what's our lived experience? How is that comparing to our understanding? Are we misunderstanding? That kind of thing. I was involved in a project in grad school on modeling pathways to concussion recovery. And so we kind of used these engaged neurosurgeons and based it on the literature and kind of say, okay, here's some of these mechanisms. And it would be, you know, great to be, there's been some talk about, okay, how can we make that more into a living model? Like how could, maybe there's ways to like periodically update it and kind of have that be a pulse of like, here's our current understanding of how a system works. Yeah.
May I ask a question?
My question online and then a
Great.
chat question after that.
Okay.
Hello, can you hear me?
Oh, I'm not hearing you. Do I need to do anything to, we need to get room audio, sorry.
Hello?
Or maybe just on your laptop?
I'll continue talking to see if you can hear me.
I'll do my laptop.
Can you hear me?
Jim, they can't hear you yet.
Okay,
You might want to mute that so we don't get feedback. All right, if you want to try again, I've got my laptop sound on.
can you hear me now?
Yes.
Okay, I have a couple of questions. Thanks for a very interesting talk. One thing that concerns me about projects similar to this is are we basically gathering what we already are doing and processing it and basically falling into groupthink? And then how this information is used is critical. And I think you talked a little bit about that. Will there be, as their willingness of the participants to see better ways of doing things? And then the third thing is one thing I struggle with at my point in my career is that we look at our own systems in public health, but we don't analyze the system that makes the decisions about funding, and particularly how in this state, how legislative decisions are made about funding. And I'm wondering if you've thought or might do some thought experiments to think about how we might apply these methods to the process of decision making around funding for public health and healthcare. Thank you.
Well, lots of meaty questions there. So thank you for that. So first of all, I need to.
We're going to mute my laptop and then unmute.
We couldn't quite hear Erin if there was.
Okay, can you hear me? Okay, so first around preventing groupthink, it's a really good question. I think, you know, anytime you have participatory processes like that, it can be a challenge. I think one thing that we've done to try to go around that is to try to balance, you know, we've tried to interview people individually first, because that's a setting where people are more likely to communicate their own ideas and mental models. And so typically what we've done is interview folks individually, use all the different interview data to create a draft, and then either engage folks as a group or engage folks individually or in subgroups. It really depends on the situation. You know, sometimes also we'll create more than one model. You know, sometimes there's maybe different mental models that different sorts of groups have, and that, you know, you can try to work at it that way. But it's, you know, these methods are just another way of communicating information, just like think of it as a different language. So it's only as good as how you design your process and how you use it. Around funding, yeah, I think there's, you know, one thing that is, you know, kind of not a danger, but just a common thing when you're doing this sort of modeling is you realize, okay, there's big big structural factors that are in play here. And the highest points of leverage sometimes are the ones that we individually have the least control over. And so that's one thing that's been really exciting about this behavioral health modeling project that we've been working on, is that we have really good buy-in from decision makers at different points in Oregon. We have folks who are really keen to be able to use this to inform some of their investments at the state level. So I think with anything, you know, we don't want to just do this and have it sit on a shelf. It would be great to be able to, you know, it's good to be able to engage folks who actually have power over some of these systems. And that, you know, just takes legwork like any other sorts of process. I see a question around undergrads and role with COSIS. Yeah, so my PhD was from the system science program, which is now rebranded as complex systems at PSU. I've actually been teaching there for a number of years, and I found that undergrads actually do really well. So I've taught them causal loop diagramming and some other sort of heuristic kinds of approaches to thinking about systems, and they tend to do really well. And you know, there's whole curriculums around teaching kids some of this too. I think people, you know, sometimes the farther you get in your education, the more deeply rooted you can be in certain ways of understanding systems. And so I found that undergrads tend to do pretty well with these methods to sort of think about problems differently. Yeah.
Can you talk a little more, I think, because I'm interested in sort of the quantitative side. So like at the end of the day, you're pulling some quantitative data out of your simulation. Is that what I'm understanding? But also, I guess my first question is sort of how do you figure out then what goes into the simulation? What goes into it? Because a lot of this you're talking about is maybe we've come up with, oh, this should be a relationship, but what's the level, or how are you varying that?
It's a lot of discussion and iteration. You know, there's not an easy, So there's a lot of kind of iteration between, let's sketch out how we think it works to see what are the different data points that we might look at as a starting point. And then, okay, what data do we have? And how do you kind of, there's a lot of judgment calls around what do you do with your data? What do you base this on? What big challenge we have right now with that behavioral health model is like, how do we factor in like different levels of acuity? How do we factor in kind of frequency of people cycling through this system? How do we kind of wrestle with like population heterogeneity versus homogeneity? And what are the limits of kind of this modeling approach? And you're always going to run into those limits, but I think you know, so back up with the simulation model, you know, you base it on the data, the best data you have. You try to be transparent about your choices. You be really clear around when we're making certain assumptions, because you have to when you're doing that sort of modeling. And, you know, it's going to produce like, okay, here's how we think certain, you know, the system might work. And when you're making a model like that, you try to calibrate and really try how you validate the model is, does it reasonably reproduce actual system behavior? You try to dial that in as much as you can. And, you know, the way I see it is, you know, this isn't like a computer that's going to spit out your right answer, right? It's a tool for overcoming our cognitive limitations in understanding all these complex dynamics. So our brains try to wrestle with this naturally. You know, we're trying to understand, okay, what's this piece of information, that piece of information, this person's perspective, that person's perspective. And we're trying to integrate that, but we have it's hard to kind of hold in, there's been research around like how many feedback loops can you kind of hold in your head and accurately produce the paper, and it's pretty low. It's like 1 or 2, you know? And so it's a tool for letting you think about all these different pieces. What's our assumptions about all these different parts? How does that hang together? How can we sort of understand what might happen? And then, yeah, iterate that too, you know, it's never going to be perfect. It's always, you know, there's a saying in system science that all models are wrong, but some are useful. And that's, you know, absolutely the case. Yeah.
I was wondering, I don't know if you've ever done this or if you've heard of it. Has the causal loop diagramming ever been used to sort of compare system perceptions across different groups? Because I'm thinking you could, the behavioral health system, you could go to the the practitioners and the experts, put a model together. You could talk to people with lived experience. You might get a completely different model.
Yep.
There might be some use in understanding what the differences in those perceptions are.
Absolutely. Yeah. There's definitely been studies like that. Even in our caravan model, you have toggles where you can toggle like what part of the model came from veterans versus non-VA clinicians versus VA clinicians. And so you can see where's the overlap, but also where's the difference, because people had different concerns. And you can't really see there what's necessarily conflicting. It was more like, what are the different pieces that people zero in on? But yeah, you can definitely look at like, because this is also a key starting point with this analysis, is that people think about situations differently, you know, and that, you know, the danger with some of this, especially the computer simulation methods, is that people are going to be like, okay, you have a software program that'll give me my policy output. Great, let's run with it. And you kind of think about it as a black box. The benefit of some of these methods is that you can take the lid off the box and really look at the assumptions. And I think it's in that, the power of that, where the value really is, you know, is not thinking of it as this sort of machine, but more thinking of it as a way to think through your understanding.
This is fascinating. I think maybe a lot of us want to take a whole course from you on these methods. I'm curious if you could talk a little bit about, you talked about how these methods could be used in examining an intervention, and like how could you combine system science with like an effectiveness analysis or an intervention?
Yeah. So we've been kind of doing this in trial and error a bit at Orphan, you know, what we found, at least with sort of within implementation research, is that it really kind of shines in a few ways. One is around sort of exploring a problem, the needs assessment, the kind of before you do an effectiveness study, like how do we understand this problem to work? And then, you know, we've also incorporated it, if we're doing like an implementation effectiveness sort of study, for example, we'll, you know, do some modeling around how do we understand this intervention to work, like I mentioned, but then also using it in the evaluation. So, you know, one thing that if we're looking at changing provider mental models, for example, this researcher reached out to me who's an expert in behavioral health integration, and he was really interested in, okay, how do practitioner mental models change over time? And so you can looking at it as like maybe a pre-post, or like what are the different phases. So, and sometimes in our evaluations, we can look at like as a tangible way of looking at like changes in understanding, or, you know, what are some of the, you know, effects. So like incorporating into some of the qualitative findings there. But it's, you know, it's an area that there isn't a ton of research on it. And so that's where we're trying to kind of trial and error. I think in terms of grant proposals, we kind of tend to like tack it on as an aim 3 sometimes of like, here's your standard method, and then here's some other fun stuff we're doing. So yeah.
This was super awesome. I've been dying to hear more about the system science from you. I know that you heard a little bit about the stuff that like our employment, like I'm like already like I'm at the chomping at the bit. I feel like you and I should chat, because I feel like our the work that we want to do to kind of unpack like what sort of collection of policies is needed to kind of move the needle on these things would really benefit a system science approach, or maybe even comparing it to like some of our like other causal inference approaches that but the grant funding piece was like, I'm like, yeah, how do you get this stuff funded?
question, you know, and I think it's, like I said, it's been trial and error. And yeah, during your presentation, you had arrows up. I was like, ooh, you know, let's, your brain might work like this too. But yeah, I mean, what we've found is that it's good to kind of loop in with some standard methods to provide it as sort of a way of, you know, just adding an extra layer basically to the understanding. I think there are some, you know, there have been NIH calls around system methods in particular, especially around simulation. Sometimes there's calls, right, you know, there's one right now looking at like intersectional social determinants and it calls for simulation in particular. So that's rare though. I think it's the challenge, I think, is how do we really integrate this with sort of more standard approaches? And I think it's, I want that, you know, I don't want this to be seen as like, oh, here's this whole other different way of doing science that's disconnected from this way. I don't think that's true. I think there's many different ways to know about systems, and these methods can just help us integrate those different forms of knowledge. And
Yeah, I was just thinking about following up on that question. People use these models to do sort of, to get to distributional sort of cost effectiveness sort of thing. Because one of the big problems is we always have like, here's the average, right? And it's like the average doesn't represent anybody. But we'd like to know people in this position, this context, get there. I'm just wondering if it seems like these models might be better at sort of pulling that apart and giving you sort of a set of answers as opposed to, or an answer space as opposed to an answer.
yeah, there's a team at UNC that did a bunch around colorectal cancer screening and cost effectiveness, and they use micro simulation modeling around that. But yeah, there's definitely possibilities there. Also, the Office of Advanced Analytics at OHSU, they use particularly like discrete event simulation, sometimes system dynamics, or you know, to help just at an operational level to look at how, you know, especially methods that can kind of combine the feedback structures with the individual modeling, like look at how many nurses do we need at certain places, or if we're kind of disrupting the system, how do we, you know, what do we need?
Thank you so much, Erin. I know there are more questions, but also I know we have to clear out this room by 11. I think we have a minute.
Oh, okay.
But thank you everyone for being here, and fantastic discussion, wonderful presentation. And we look forward to seeing you at the next one. We're in the midst of scheduling it for winter, but you came last year, I think, to see. We had Marissa and Nikki, and now Erin, and we'll see who's next. One of our new faculty, perhaps. Making eye contact with one in the room, just looking away from me. But we'll see you in winter, and thank you all so much. Please take a donut. Did I mention there are donuts?
Thanks so much, everyone.
So I'm pretty sure we're